Hey folks, so this is our last lecture for the week and we will finish this up the following week just in time for your final exam, or your fourth exam, and then your final for those of you who are choosing to take it. We are going to talk about psychological disorders. So I want you, this is an area that I think many of you will be very interested in. Odds are pretty good that you know somebody who is struggling with a psychological disorder of some kind, or maybe you yourself are doing that. So hopefully some of the ideas that come up in this lecture and some of the ideas that you have as you're listening to this lecture and reading the book will help you think more deeply about mental health and how to take care of your mental health and how to support others when they're struggling with their mental health. So how do we think about moments of mental illness? So I want to be kind of clear. We all have moments in our lives of anxiety, of sadness, and of grief. So the question becomes, when we're talking about mental health and we're talking about psychological disorders, Earl says hello, where do we draw the line between what we consider ordinary or normal and what is not? So this is actually something that is coming up quite a bit right now. So for those of you, just in case you forgot, we've been in a global pandemic for about almost a year now. So it's been almost 9 months since here in the United States, we started taking it seriously. And so many of us are more isolated than we normally were. Many of us are missing out on opportunities or have lost jobs or have family members who have lost their lives. And even for those of us who have not lost a job or have not lost a life, I know I'm several states away from my family, and that makes it really, really difficult to have been able to see them this year. Additionally, there are things that I know I've been looking forward to that, at least for right now, I am not able to do. I can't go to the movies with my friends and hang out. I can't go to a concert. I mean, I probably could do those things if I really wanted to, but ultimately it's a risk assessment. So a lot of us are having, are struggling with having these hopes and these ideas that we had for this past year. We've had to recalibrate those ideas. We've had to learn how to be a little bit more flexible and try to adapt. And some of us are doing that really well, and some of us are not. And so some of us are beginning to show signs of poor mental health. People are reporting having depressive-like symptoms or anxiety-like symptoms. And these are people who had not necessarily have done those before. And so the question becomes, is that actually a psychological disorder? Are these people depressed? Or is this a completely natural way to act in a very unprecedented situation? At least for most of us who are alive today, this is unprecedented. So the question becomes, would we consider this normal, or would we not? And that's been a subject of debate for the past few months. So when we talk about psychological disorders, we are diving into the realm of clinical psychology, which is sometimes referred to as abnormal psychology. And this is all about understanding and classifying and treating different types of disorders. So what is required for something to be a psychological disorder? So I'm going to use myself as an example, and I hope that for many of you this is not too personal. So I occasionally struggle with anxiety. I am somebody who thinks a lot. I've occasionally been told I'm intelligent. Whether or not that is true is another matter. I don't necessarily always think of myself as very smart, but I am somebody who thinks a lot. And I'm very analytical. It helped me get all of these ridiculous degrees being a very analytical person. And sometimes I'm to the point where I am over analytical. I can see multiple different things, and I am hyper aware of myself and how I come off and my mental states. And because of that, when I got a diagnosis of generalized anxiety disorder a couple of years ago, I was not really all that surprised. I am somebody who is incredibly prone to overthinking and overanalyzing and finding myself kind of paralyzed by that. And I have a lot of extra nervous energy running around. So when we talk about a psychological disorder, it is going to be an ongoing pattern of thoughts or feelings that are deviant. So when I mean deviant, this is something that most people would not do. So most people do not have panic attacks like I was having, and they certainly don't have panic attacks in regards to people at work. So, you know, that is deviant. Now let's be really, really clear. What we consider deviant is largely defined by our time and our culture. So for example, if you came to me and said, Dr. Gilchrist, I've been hearing voices. These voices have been telling me that the television is trying to control me, and that bad things are going to happen really soon. These voices are telling me I need to hide, that bad things will happen to me. If you report hearing voices here in the United States, that is a cause for concern. And I would potentially wonder if you might have something like schizophrenia. Now, on the other hand, depending on the culture, if you said, I'm hearing voices, these voices are telling me to give up my possessions and be holy. In some cultures, hearing voices is not a sign of mental distress or mental problems. It is rather a sign of favor by a deity, or it is a sign of spiritual enlightenment. So time and culture largely define what we consider deviant. For example, and I think it needs to be said, please remember that being gay was at one point considered a psychological disorder. And now it is no longer. And because it's defined by our time and culture. These things need to be distressful. So the thoughts and the feelings need to be distressful. And I can tell you, when I started having panic attacks out of the middle of nowhere a couple of years ago, and really negative thoughts about myself, and especially when the panic attack showed up, I'm like, that's not normal for me. Like, I know what my normal is, and this bothers me because this has never happened before. I'm waking up in the middle of the night and thinking I'm having a stroke, and I'm clearly not having a stroke. And then finally, it has to be dysfunctional. It has to interfere with your everyday life or functioning. And I know for a while, I was changing my behavior and doing everything I could to try to keep those panic attacks at bay. Now, you might be kind of curious why I have generalized anxiety disorder and not something like panic disorder. The panic attacks didn't happen that much, and additionally, a lot of my distress was existing before the panic attacks. So I was working myself up into them. They were not necessarily popping up out of the blue, as often happens with panic disorder. And we'll talk more about that soon. So it has to be dysfunctional. It has to interfere with your everyday life in some way. So these are our 3 Ds. And I would also mention that distressful does not necessarily have to be distressful to you, but it has to be distressful to someone else. So if you are drinking and driving, maybe that doesn't bother you, but that's going to bother somebody, and that's putting your life and the life of other people at risk, and that is highly distressful, even if you do not think so. So one of the things that's actually kind of interesting is how much our understanding of mental illness has evolved, especially in the past 400 years or so. It was originally believed that if you were suffering from mental illnesses, these were because of demons and supernatural forces. And because of that, there was a lot of belief that if you had these things, well, you must have done something bad to bring the demon in. And so it kind of justified some verifiably inhumane treatment. People being locked in cages, people not being allowed to go outside. And generally, people with mental disorders were treated incredibly poorly up until about the 1700s or so. And one of the first people to really advocate on behalf of people who were struggling with their mental health was Philippe Pinel. And he actually argued that putting people in these torturous cage conditions was definitely not helping their mental state. Mental sickness rather was something that was due to stress and the inhumane conditions that these people were often put in. Often made things worse. And so he advocated for what is referred to as a moral treatment. So this includes things like taking people outside, not putting them in cages, keeping them in a safe, healthy environment. Like, the goal here was try to boost morale, basically talking with them, learning about them, replacing isolation with activity. And having said that, we have done some really terrible things on behalf of people with mental illness. Even back in the early 20th century, it wasn't that uncommon for people who were struggling with mental disorders, particularly the ones that are a little less palatable, so to speak, like schizophrenia, the ones that are kind of difficult for people to talk about and are poorly misunderstood. It wasn't that uncommon to sterilize them. And that was one of the big part of the eugenics movement, was basically people with these kind of weaknesses, with these kind of sicknesses, were not permitted to breed. Additionally, in certain psychiatric hospitals, it wasn't that uncommon to see people chained to beds. And those are things that we still sometimes see today. Something that has really kind of shifted, in addition to our moral treatment, something that's kind of shifted our understanding of mental illness is basically the finding that a lot of psychological disorders have physical causes. So one of the first major findings that we had regarding this was basically so syphilis, the sexually transmitted infection, it is curable. We have antibiotics for that, but at a previous point in time, antibiotics did not exist. And so if you got syphilis, there was no cure for it. And one of the things that we know is that syphilis could affect the mind and the brain in its later stages, including things like hallucinations. And this basically led to the finding that mental disorders could potentially be due to physical causes, like actual physical illnesses. And because of it, these causes could be diagnosed, treated, and cured. So with this, we start to see a greater shift toward the role of hospitals in treating mental disorders and a greater reliance on medication in particular. And additionally, our findings about the brain and neurotransmitters and the role that they might play in disorders has also really forwarded the medical model. It is very, very common and has gained a lot of traction, the notion of a chemical imbalance that causes something like depression or anxiety. And so we have a lot of support for this medical model. However, remember that we're talking about psychological phenomena here. It is not purely a biological thing. Biology plays a role up to a point, but there are other factors that will explain why a disorder may or may not develop. So remember your biopsychosocial approach. There's more to psychological disorders than neurotransmitters and genes. Just because you have a family history of a certain type of mental disorder does not necessarily mean that you are going to get it. Now, genetics does play a role. Mood disorders like depression or anxiety disorders, they tend to run in families. But there's more than biology here. Environment and culture also play a huge role here. Sorry about that. My cat opened the door to my room, so I needed to close it. So here, for example, we have some culture-bound diseases or disorders, things like cysto So in Latin America, for example, this is a case where people have severe anxiety, restlessness, a fear of black magic. In countries like Japan, we have something called Taijin Kyofsho, which is basically social anxiety about appearance, particularly with respect to blushing. And here in the United States and in other countries in the Western Hemisphere, we tend to have more eating disorders like anorexia nervosa and bulimia compared to other countries because of that super rigid standard of beauty and the images that we are shown in advertising, television, and movies. In addition to that, there are certain types of personality characteristics that will also affect whether or not you end up developing a disorder. So for example, something like depression that we tend to find is that a lot of people who struggle with depression have what is called a negative explanatory style. They have certain personality traits and characteristics that make them internalize and blame themselves for the bad things that happen to them. And because of that, and the way that they see the world and the way they think about things, that actually enhances the cycle of depression. And we'll talk about that more next week. So how do we classify and diagnose the different disorders? So one of the things that we're going to find is that classification is a double-edged sword. Classification can be a really great thing. It describes behavior. So when I say that somebody is struggling with major depressive disorder, you already know what that means. You know that because we have this classification system, when I say that somebody is struggling with major depressive disorder, you know what kind of things you are going to see ahead of time. So it describes behavior using a very similar sort of language, and it also permits a prognosis as well as a means of treatment. Now, on the other hand, one of the things that we will find about these classification systems is that they create labels. And I can tell you, as somebody who has been diagnosed with certain types of things, I think that the label can occasionally be very useful to explain why I work the way I do, why my mind works the way I do. But many people may find the use of a label very, very limiting. Now, likewise, labels, if you tell somebody that you are struggling with a disorder, they may only view your behavior through the lens of that label. And we'll kind of talk about that a little bit more with a very, very famous study by Rosenhan and colleagues coming up. But what do we here in the United States use for our classification system? So we have what is called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. The DSM-5 was finalized by the American Psychiatric Association back in 2013. And it has actually created a lot of changes in terms of how we see disorders compared to how we previously did. So what changed with the DSM-5? So your book talks about some of these as well too. So one of the things that I actually really liked about the previous DSM, and I mostly learned about this because I was a teaching assistant for an abnormal psychology class when I was in graduate school. And I'm going to tell you the truth. It was the first time I'd ever taken an abnormal psych class. I didn't take it in college. I was firmly on the cognition track. I'm like, I don't want to learn about disorders. I just want to learn about cognition. But one of the things that I thought was really cool about the previous system, which was the DSM-4-TR, is that they had what's called a multi-axis system. So the major psychological disorders were what were called axis 1, personality disorders were axis 2, and then the remaining axes were for things like environment, what other conditions that are not psychological might potentially be explaining why this person is struggling in this way. And then on the fifth final axis, it was basically like a score kind of based on the general outlook of this person. So I actually kind of liked it because it had a very holistic way of describing not only the disorder itself, but also how this person was coping in their lives, what sort of things were going on in their lives to potentially contribute to these issues, and also providing a means for prognosis. The DSM-5 basically got rid of this multi-axis system. Additionally, there are major changes to disorders. Probably one of the best known is that prior to the DSM-5, different types, autism basically came in different forms. So for quote unquote high functioning, I don't like using that term, but basically for people who were very highly verbal and didn't really have significant intellectual impairment, but they still showed features of autism, they would be diagnosed with something like Asperger's syndrome. Other people would be diagnosed having a persistent developmental delay, not otherwise specified. And basically what ended up happening is all of these different types of autism basically got merged into autism spectrum disorder, or ASD. There are OCD and PTSD basically got reclassified as PTSD is now a trauma disorder. OCD is considered an impulse control disorder. Both of these were previously considered types of anxiety disorders, and as we're going to see later on, they have certain features of anxiety disorders without actually being anxiety disorders. Major depressive disorder basically got rid of something called the bereavement exclusion. So if you were grieving the loss of a family member or a loved one, you could not be diagnosed with major depressive disorder until you had been grieving for more than, I believe, 6 weeks. They got rid of that exclusion and basically said you could be diagnosed with depression if you were in the midst of bereavement. Additionally, we also added a binge eating disorder, hoarding disorder, and premenstrual dysphoric disorder, which is not the same as premenstrual PMS, premenstrual syndrome. This is dysphoric disorder to the point where it makes you feel terrible and really messes with your ability to function. So we've had some major changes here. Here are some of the pros and the cons. Generally, what we're going to find is that the categories and the criteria tend to be pretty reliable. Now, with these new criteria with the DSM-5, the agreement has actually been much, much harder. So your book actually talks about this, looking at the reliability of diagnosis. Generally, there's a lot of agreement on PTSD. The hallmarks are pretty straightforward there. Childhood autism spectrum disorder, we do a terrible job diagnosing it in adults because we assume that this is something that you should have found in childhood. Additionally, we also have a hard time doing it with disadvantaged groups. Generally, women and girls have a harder time getting diagnosed with ASD. We know that Black Indigenous people of color have difficulty getting diagnosed with autism in general because they tend to be overlooked. Autism spectrum disorder for kids, largely psychologists doing these diagnoses are largely in agreement, but for things like antisocial personality disorder and generalized anxiety disorder, we actually tend to see that agreement drop all the way to 20%. So the criteria have gotten a lot easier, but sometimes that makes them less reliable. And one of the things that was a major talking point back in 2013 when the DSM-5 came out was that under these current criteria, 50% of the US population is going to be diagnosed as having a mental disorder or will fit the criteria for having a mental disorder at some point. Now, why is that? Well, easier criteria means that it's easier to detect. And it's possible that we may be getting sicker as a culture. One of the things that I find really interesting is that up until very, very recently, the most common disorder was major depressive disorder, and that's shifted to anxiety. More people struggle with anxiety now than with depression, and I find that really interesting. Is there something going on in our culture that makes us more apt to feeling anxious? And I would argue, at least right now, there's a lot. Additionally, there are more categories with easier criteria. So it becomes easier to take something that's quote unquote, that's kind of normal, standard human behavior, and then basically say, aha, that behavior is disordered. And we start to view it through the lens of a disorder rather than a normal response to circumstances. So I want to go back to that study by Rosenhan. So this is a pretty famous study. Labels can really bias how we see people. So David Rosenhan and about 7 other people basically went to hospital admissions offices, and they basically said, we're hearing voices. They weren't actually hearing voices. They just lied and said they were hearing voices so that they could get admitted to the hospital. Now, what's really interesting is that everything that they kind of talked about started to be viewed through the lens of a disorder. Most of them were in that hospital for 19 days. Up until being released an average of 19 days later, these 8 patients showed no other symptoms. Yet after analyzing their life histories, clinicians were able to discover the causes of their disorders, such as having mixed emotions about a parent. So one of the people in this Rosenhan study liked to keep a journal. And even that now we'd consider journaling good. In fact, a lot of therapists will tell you journaling is a very healthy activity. But what's interesting is that this person's journaling was viewed through the lens of a disorder, and all of a sudden it wasn't, oh, he's journaling, he's trying to keep his mind healthy. It became, this is part of his mental problems. He obsessively writes in this notebook. So all of a sudden, once we label somebody as having a disorder, everything that they do becomes labeled through that disorder. And here's the thing, I have anxiety. I have generalized anxiety disorder, and I'm also neurodivergent. Those are parts of me, but they're not all of who I am. And I'm sure that that's true for many people as well. They have a disorder, but that's not all that they are. So that's just something to kind of think about. So I'm going to go ahead and stop here. And we will start talking about the different types of disorders next week. And we're going to start by talking about, well, something that I understand very, very well, and maybe some of you do too. We are going to talk about anxiety disorders. So have a wonderful week, and I will see you all very soon. Bye.